Ladies and gentlemen, announcing the arrival of our national icon, Yang Berbahagia Tan Sri Dato Sri Dr. Noor Hisham bin Abdullah, Director General of Health Malaysia. Thank you. Please be seated. Yang Berbahagia Tan Sri Dato Sri Dr. Noor Hisham Abdullah, Director General of Health Malaysia. Yang Berbahagia Tan Sri Majid Khan, Deputy Chairman of KSI. Yang Berbahagia Tan Sri Michael Yeo, President of KSI. Excellencies, distinguished guests, ladies and gentlemen. On behalf of all the delegates of the Malaysian Healthcare Conference 2020 and staff of KSI Strategic Institute for Asia Pacific, I'd like to warmly welcome Yang Berbahagia Tan Sri Dato Sri Dr. Noor Hisham Abdullah, Director General of Health Malaysia, to this year's Malaysian Healthcare Conference. It is indeed an honor to have a national icon in our midst, and we are most delighted for his presence with us this afternoon. Without further ado, I'd like to hand over the floor to Tan Sri Michael Yeo to present his introductory remarks and to do the conferment honors.
Yang Berbahagia Tan Sri Dr. Noor Hisham Abdullah, Director General of Health. Yang Berbahagia Tan Sri Majid Khan, Deputy Chairman of KSI Strategic Institute. Excellencies, Tan Sri Dr. Dato, distinguished speakers, ladies and gentlemen. I'm very delighted to welcome here someone who has gained the confidence and support of our whole nation, who has somewhat now become a national hero, Tan Sri Dr. Noor Hisham Abdullah. We are all very grateful to Tan Sri for having led the fight against COVID-19 and who has calmed the country through his cool, steady, professional briefings and updates, initially on a daily basis and now still on a regular basis. We are indeed very fortunate and delighted to have Tan Sri Dr. Noor Hisham to be with us here this afternoon to share with us further insights on the fight against COVID. In the brief discussion we had earlier before entering this hall, I remember Tan Sri Dr. Noor Hisham said, the war is not yet over. And I think we still need to continue to pool our resources together to fight COVID and to give our fullest support to the Ministry of Health and the government in this journey. Tan Sri Dr. Noor Hisham will also be willing to have a dialogue with us and take some questions from our participants after his presentation. But before we commence the presentation and the dialogue, we would like to confer on Yang Berbahagia Tan Sri Dr. Noor Hisham, the National Icon Lifetime Achievement Award for Leadership in Public Health. We believe this is a very well-deserved honor. This is in recognition of Tan Sri Dr. Noor Hisham's leadership in public health care, particularly in this fight against COVID-19. This conferment also recognizes his many years of services to the Ministry of Health, and it also enables us to recognize and thank the Ministry of Health for their support, for their leadership of this battle against COVID-19. Recently, Tan Sri Dr. Noor Hisham has received several well-deserving awards. The conferment of the Panglima Setia Mahkota, the Tokol Ma'al Ijra Award, the Brand Laureate Award from the World Brands Foundation. Today we add to the accolades Tan Sri Dr. Noor Hisham has received by conferring on him, on behalf of all of you, the National Icon Distinguished Lifetime Achievement Award, which celebrates Tan Sri as a national hero and a national icon of Malaysia. It is my honor to now call on my fellow directors, Tan Sri Majid Khan and Dato Hassan, to join me on stage to make this presentation to Tan Sri Dr. Noor Hisham. Thank you.
Ladies and gentlemen, another round of applause for the conferment of the National Icon Lifetime Achievement Award for leadership in public health to Yang Berbahagia Tan Sri Dato Sri Dr. Noor Hisham Abdullah. Thank you very much. Congratulations, Tan Sri. Distinguished guests, ladies and gentlemen, Yang Berbahagia Tan Sri Dr. Noor Hisham has graciously agreed to a special dialogue with us this afternoon, focusing on COVID-19, Malaysia's journey towards flattening the curve. And now I'd like to hand over the floor to Yang Berbahagia Tan Sri Dr. Noor Hisham Abdullah.
Thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good afternoon. Yang Berbahagia Tan Sri Dr. Michael Yeo, President of KSI, Strategic Institute for Asia Pacific. Yang Berbahagia Tan Sri Majid Khan, Deputy Chairman of KSI, Strategic Institute for Asia Pacific. Your Excellencies, distinguished speakers and guests, members of the media, ladies and gentlemen. First and foremost, I would like to thank Tan Sri Michael Yeo and the KSI Strategic Institute for Asia Pacific for awarding me this conferment. But more importantly, this is on behalf of the frontliners and the Ministry of Health. And I think it is because of COVID that most of us, been appreciated for what we do. Without COVID, probably nobody knows us actually. So that's public health. When things goes right, when we are able to perform well, nobody knows about public health. Today, because of this pandemic crisis, many of us appreciate the role of public health in the society. So I think we need to focus and invest more in public health. And this is certainly an opportunity for all of us here to do things right for the country. It is not because we are the last line of defense. If we can make it right, we can save the country. As I always say, I'm a surgeon. I can treat one patient at a time. I can save one life at a time. But public health, if we do it right, plan it right, we can save the whole country. So this is very important for us. The top brains must be in public health, not in cardiology, not in endocrine surgery, but in public health. And we are under-investing in public health. Today is an eye-opener. Every sector is a health sector. Ministry of Health is leading every sector. No one is left behind. And more importantly is that coming together as one, working as a team. And today we are very lucky because we have a Prime Minister that listens to the civil servant, that listens to the Ministry of Health. Imagine if there's a president that's not listening to the technocrats, then it was just going to be a disaster. So I think because of that, we managed to, so far, we have won a few battles, but we have not won the war yet. So I hope that today we can share our experience and perhaps cut short the presentation, and perhaps we can have the dialogue section with the audience. With that, ladies and gentlemen, thank you very much for your attention.
Thank you, Tan Sri, for those timely remarks. I'd like to invite Tan Sri to take his seat, and now I'd like to hand over the floor to Tan Sri Michael Yeo, who will be moderating this very special dialogue session.
Well, ladies and gentlemen, can you hear me? Tan Sri Dr. Noor Hisham is willing to take some questions for us. I think it's a very good opportunity for us to be updated on what the government, in particular the Ministry of Health, has been doing when the fight against COVID. I'd like to invite questions from the floor. But before that, can I perhaps ask Tan Sri? The Ministry of Health has now recommended an extension of the RMCO. How long do you think this RMCO will be extended for?
Well, first and foremost, we need to look into the development, the global situation, where they are and where are we. So, but I have a concern. There are 4 situations that we look into. The 180 countries been affected. Situation number 1, they are well controlled. It's like New Zealand before, but they have more than 100 days, they do not have any cases. But then now we realize that there's actually a surge of cases now. So situation number 2, this is like Malaysia now. We are able to control and contain, but it's still ongoing war. Situation number 3 is that when you have a first wave, then just like New Zealand, you are doing well. Then you have a second wave now, exponential surge. Our concern now, if I can show you the first slide, you look into the slides. Can I have the next slide? Our concern is that the second wave is coming. And this is what we have been told. The second wave is more, in terms of more difficult to handle, and the cases will surge worse than the first wave. At the moment, 188 countries already been infected. 23.5 million people globally have been infected, and death rate is about fatality is more than 800,000 cases. And looking into these current slides, once upon a time, I think we are able to control like Korea, Hong Kong, Japan, Australia, and New Zealand. Now the cases now are increasing, and worse still in the next 4 months. We must be prepared for the worst, because winter is coming in Europe and etc. So the impact probably we will get a second wave. My concern is the second wave will be worse than the first wave. So if that's the case, we must be ready to strengthen and tighten our border in our control of COVID infection in this country. And you look into the distribution of the COVID cases. I think when we have a new government in place, and the first day I briefed the Prime Minister the current situation, and certainly I was worried because there are 3 factors. I told the Prime Minister the tsunami is coming. And so he said, what do you mean by tsunami? Because number 1 is that we looking at the JP Morgan prediction, we will have 6,300 cases on 14th of April. And the Malaysian Institute of Economic Research predicted that we will have 8,000 or 9,000 cases on the 28th of April. So we were in March now. So we need to prevent all these issues. So unless we have to take good strategic action, then only we can prevent all these figures being predicted. That's number 1. Second is that school holiday is coming. And during the school holiday, I was told 8,000 or 10,000 of the teachers from the Ministry of Education already been given approval to go overseas during the 1 week. And winter sonata, cherry blossom, and etc. So this is a regular thing, because we like to go to, to feel for this holiday, short holiday. And our concern is when they come back. When they come back, they'll bring the infection, because the 5 countries been identified then was Japan, Korea, China, Italy, as well as in Iran. So that was number 1. Second is that on the 9th of March, I got a call from my counterpart from Brunei saying that one of the citizens, their citizen positive for COVID-19, attended the gathering in Masjid Steve Taling. And when we went down on the ground on the 10th, most of them have left, because their gathering was on 27th of February until 1st of March. And there were 16,000 people gathered there, 1,500 from foreign guests, and 694 from Indonesia. And at that point of time, we know in next 2 weeks or 3 weeks, we are going to face a disaster. In that sense, the cases will surge exponentially. And we also predicted then India will be the next epicenter, because some of the Malaysians left and then went to India, and more than 150 of them. And then recently we have to bring them back. So that's another one. And Indonesia, and we were worried about Indonesia. At that point in time, we know that probably the infection was from Indonesia. We assume it's from Indonesia. because we had a Thaipusam celebration, no issue. We have a Cap Gomez celebration, no issue. But here, because 695 of the Indonesian participants were there, and today we look into the genomic sequence, then we know that our virus was coming for the Tabligh group, and also the immigrants were coming from Indonesia. That is a strain C virus. So this is why we have this data to substantiate that, you know, it's not only an assumption, but the cases are actually coming from Indonesia. Our first wave was from 25th of January until 16th of February. We have 22 patients directly or indirectly related to tourists from Wuhan. So, and the genomic sequence shows that they are strain B, that is actually from Wuhan. So we have documentation. Then we have a period of 11 days, we do not have any cases. Then thereafter, after the 11 days, then Malaysian returnees, case 23, case 24, from overseas coming back, bringing the infection. So that's the fear that we have is, you know, if we do not lock down our border, that will be a disaster. And more patients, more returnees coming back, and then they'll bring the infection. So, and you look into our persuasion with the Prime Minister then is to lock down. So it's not an easy decision because at that point of time, only China, Wuhan, they locked down the area and there was, the 5 provinces. But then we convinced the Prime Minister to do so. If you do not do this, then we'll miss the boat. We have a small window of opportunity then because we are still looking into the burning ember. But once it's a wildfire, then probably you and me will just watch, and then it's the mitigation phase rather than prevention. So the Prime Minister hastily at that point of time agreed to the lockdown. But we did not announce 6-week lockdown because you know, probably mind conditioning of the public. It takes time for our public to, you know, to accept a 6-week lockdown. But we announced every 2 weeks, MCO1, MCO2, MCO3. And then our strategy then was to look into locality. So instead of testing everyone, targeted approach. You know, we do not do carpet bombing. It's just like, I'm an oncologist in terms of treating breast cancer. So those days we treat with carpet bombing, and then all normal cells and all the cancer cells would die. But using the same principle, we just use in public health, targeted to a certain group or locality. Then we test everyone there. So in the MCO, for example, movement control order, we have a minor war, I would call it. Then we identify the area, for example, enhanced MCO. In enhanced MCO, we lock down the area, we test everybody. And whether you're local, whether foreigners, illegal or legal, we do everyone. And then we identify the cases. So the thing that we are doing difference is that positive cases, we'll admit them in the hospital. And whether they are symptomatic or asymptomatic. Negative cases, we will isolate them and quarantine them. That's what our strategy from day one. And targeted. Targeted means you are not doing less, but targeted to certain group and locality. So during the TEMCO, or TEMCO means targeted, or enhanced MCO, EMCO, we lock down the area, we do the test for everybody. So that is our strategy in terms of how we implement. So we won the war of MCO1, MCO2, because when we see the MCO1, you can see the graph, MCO1 and 2, the cases are peak, but it's less than 6,300 as predicted. It's only for 4,000 plus. Then we thought that we are expecting an exponential surge, but it came down. MCO3, we saw that the cases are going down. MCO4 is already almost down. So we, not in our wildest dream to get 2-digit or even a single digit, but we managed to bring it down. So once we have brought down the cases, because this MCO is a very artificial environment, which means everybody stayed at home. The principle is stay at home, so that to allow public health to take intervention, case detection, and etc. So it gives us the opportunity to contain the infection and prevent the surge of cases. Then once successful, then Prime Minister is telling me, one day it costs us about 2.4 billion ringgit, you know, our economy will go down. So okay, so we understand. So we switched our strategy to CMCO. We allowed the economic sector to resume, but with the caveat that you follow the SOP. And then other sectors, for example, social sectors, education sectors, put on hold yet. So we continue the CMCO. So when we continue the CMCO during the Hari Raya, so we are worried the balik kampung and etc. So we managed to, you can see the 2 spikes because we were after the migrants, for example, foreign migrants, legal and illegal. And you can see the illegal, because about there was 2 spikes there, but it's contained. It was contained in the detention center, so it's not in the community because we took action early, and then the cases came down. So once the cases came down during CMCO, so we planned for the next strategy. We won the war of MCO, we won the war, the battle of MCO, battle of CMCO, and now we are in the battle of RMCO. And RMCO, you can see initial phase, we were doing very well. Everybody comply, adhere to the SOP. But towards the end, we can see there is actually success actually breeds of complacency. Complacency then eventually leads to failure. And before we start the MCO, our R0 is 3.55, meaning 100 people have been infected, they will infect 355 people. So we are in acceleration phase. So we managed to bring down the R0 during the CMCO to 0.33. That means 100 people infected, they only infect 33 people. So we are in a recovery phase. But when the R0 went up to 1.3, that means 100 people infected, they will infect 136, so it's climbing. Our critical level will be 1.6. Once you reach 1.6, it will go exponentially surge upwards. So we need to prevent the R0 from reaching 1.6. So today we managed to sound the alarm. Then in the mid-RMCO, we brought down the incidence to 0.7. So we are still all right. Today, we have 11 cases, 2 imported and 2 imported cases, and then 9 locally transmitted cases. So we still, yesterday was better, single digit. So we are still able to contain the infection. Next. So this is our strategy, looking into the movement control order, I already explained. Then we prepare ourselves. We were not in denial. We know that in some point of time, the infection will reach Malaysia. So we have 2 months ahead. Once the disease is been detected in Wuhan, so we look into our diagnostic and testing. To fight this war, we must be able to identify our enemy. And our enemy is invisible, so we look into our lab. So the moment 3rd of January, China released the genomic sequence, we already prepared our RT-PCR at that point of time, trained our public and also the private lab to get ready. So we started with 23 labs, and we are able to do about 1,000 tests a day in January. Now we are able to do about 38,000 tests a day in 58 of our labs. So that's the diagnostic testing. Then surveillance, public health is important. So we have training, looking into active case detection, our communication, organization, everything put in place based on the experience that we have for SARS, MERS-CoV, etc. But more importantly is this is a larger scale. So we not only prime the Ministry of Health, but also other ministry. For first time in history, every sector is the health sector. For the last 2 years ago, when I talked to other ministries, every sector is health sector, nobody believed me. But today, we live the day to see every sector is health sector because we need to brief them, we need to integrate our services, for example, and we have to authorize other ministries to, in the Act 342, we have an Act 342, there's a Prevention and Disease Control Act, whereby we drafted it in 1988. So we are implementing it for the whole country. So this is important because police is doing for army, police, immigration, tightening borders, etc. So they come together for us to enhance it. And whatever decision that we make, this is a new virus. So we do not have experience with this new virus. If you have a relationship with the virus, every day, each day brings new lesson and knowledge for us. So our guidelines keep changing, to cater for learning a new information. And we already have a 5th edition of guidelines for us to do it. So it's just like you having a relationship, to know a person, 6 months is not good enough. Probably if you have 2 years, and then only you know the behavior of the person. Likewise, we are trying to understand the behavior of this virus as well. So it must be evidence-based approach. So we adopt the evidence-based approach. And I mentioned about isolation and treatment. All positive cases will be admitted into the hospital, and we will isolate them and give them the proper treatment. Then the negative patient exposed to positive cases, we will quarantine them. And the most important is risk communication. Now you look into Ibu Sina before, those days, the first thing is you have to calm the public. And this is what is our role. To calm the public, there's a lot of rumors, so it must be based on science and data, rather than the fear as well as rumors. So we came together to look into strategic communication, and the only way to calm the public is to make them understand the situation, sharing the data, explaining issues and challenges, and then to build trust. And then once they have trust, then probably, hopefully, they will comply and adhere to our SOP and etc. This is a strategic communication. Every day we are reminding. So my press conference, we have 4 components. First is we look into the data of the day. Second is that we highlight some issues to be addressed. And third, we look into the reminder in terms of the in terms of hand washing, 3W, and then 3C, for example. And fourth is open, question and answers to the public. You can ask us anything, and we try to address it. So to build trust, this is what we need to engage, we need to explain, and then we need to build the expectation. And our job is to deliver beyond that expectation to build trust. So the most difficult challenge that we have is to manage the public expectation. So we took some time to get this expectation going, and hopefully the trust is there. So I think that's the reason why we have daily communication with the public. And you look into our figures today, we have done more than 1.1 million tests, individual testing, and then our test per 1,000 population is 36.3, which is actually, a lot of people say that we are under testing. No, we are not under testing. We are equivalent, if not better, than many countries. Positive rate is 0.78. And if you look into our screening for pre-operative cases, pre-op cases, we have done more than 1,000 cases. And our positive cases is 0.05, which means the disease, the virus is still contained in our community. Our fatality is 1.35, is among the lowest in the world. Recovery rate very high. And of yesterday, we have 184 cases, that is positive cases been isolated. Although they are asymptomatic, we still isolate them in our hospital. Then in some countries, they isolate them at home. So we do not isolate our positive patient at home. ICU, I think now, we have, at one point in time, we have 200 patients in ICU. Now only 8 patients in ICU. So you look into this from the Oxford Martin School. Malaysia, we are doing 36.35 tests per 1,000 population. Our positive rate is 0.78. South Korea, they are doing about 34, almost equivalent with us, but their positive rate is much higher, 1%. Now, you look at Singapore, they are doing more than us, 125, but their positive rate is 7.6. You look at US, they are doing more than us, 216 tests per 1,000 population, but positive rate is 7.9. WHO have come up with a statement, if your positive rate is high, that means more out there will not be detected. That means you have to do more tests to detect. That means because your positive rate is high. But your positive rate is low, that means it's adequate, it's controlled. So among the tests, you look into the tests, 36 and South Korea 34, so we are doing more. But our positive rate is much lower, 0.78. So if, for example, in one country, the detection, the positive rate is 10%, that means you have to do more outside. If it's 50%, that means 1 in 2 is positive, you have to do more tests, so your test is, so what is the normal, acceptable testing? So we look into this in terms of positive rate as well as the test per 1,000 population in our population. And obviously, social compliance. Now, the onus to win this war is not only a Ministry of Health or the government, but the public must come together. If the public continue to have demonstration here and etc., that's the beginning of the end for us to contain the infection. But social compliance and social responsibility, social discipline is important. So you see some of the countries, for example, in Japan and maybe in Korea or as well as Taiwan, they are doing well because they know about war, the discipline. They have been to war before, so they comply. So ours probably we have never been to that situation, but more important is to win trust and then to understand the subject matter so that they have less fear and then we'll continue to pursue it. So this is the struggle that we have, balancing the economy and the disease, life and livelihood. So our strategy, MCO, basically is to focus on the disease, the virus. And then we also have to handle the viral and social media, which we are doing it through the strategic communication. but the livelihood as well. So this is the balance we have, and that's why we changed the battle from MCO to CMCO and then to RMCO. So this, the financing is important, so investment, the government and everyone must understand that public health is very important, you know, as compared to other specialty. But we are under-investing in public health. And in short, I think working together as a team. So what we have done is the leadership in the government, we have actually adopted this whole government and whole society approach. So every one of us have a role to play, you know, probably in a different capacity. But coming together, we have one intention, that is to break the transmission of COVID-19 in this country. So, and also we look into the behavior modification, and now I think we have 6 strategies that put in place. Number 1, tightening the border control. Second is look in our healthcare facilities. You know, most of us here know that even before COVID, our public hospitals were already congested, but we managed to decant some of the hospitals, 7 hospitals become COVID hospital only. And then services, we use a district hospital and etc. We decant it to a lock, stock and barrel, and then they can actually continue to function in district hospital. So a lot of planning done earlier. And the third is that public health intervention. We need to look into the system, activate our CPRC, activate all our experience from the past, and then we put into practice. Fourth is we need to protect the vulnerable population. This is where old folks home, for example, we are protecting, and the Orang Asli, even in Sarawak for longhouses, for example, from day one, they have stopped visitors coming to their kampong, for example. So this is something that it's an ongoing process. Fifth is that we need to educate the public. This is where strategic communication comes in, educate the public. Last but not least, only 2 weeks ago, Prime Minister have launched it, that public empowerment. We want the public to, from bottom up, you know, to look into this issue. You yourself, for example, you realize that who is wearing the pink bracelet, you know, then if it's crowded places, you call the police for enforcement, etc. So we have actually delegated our power to the respective public servant. For example, police, AG, and etc. They are doing their part, we are doing our part. So it's actually a whole holistic approach to tackle this infection. So I think if we all can be together and then be united, I think we can beat this infection. But it takes time. But now we need to prepare for the worst and hope for the best, because the next 4 months is going to be very challenging. If it's going to be worse than the first wave, we must be ready, because you know, if we are not ready and let our guards down, that's the beginning of the end. Once we open up our border, that's it, you know. And then once it's a wildfire, it's just like in Australia, the wildfire, everybody just watch and run away because we cannot contain. Now we are in a containment phase, and it's very important each and every one of us comply to the SOP. SOP is simple. So physical distancing, for example, in the MCO, we are talking about social distancing because you stay at home. There's no social. Now is physical distancing. Keep a distance about 1 meter and so on. Put on a mask, for example, hand washing, and then stay away from crowded places and etc. So if you can comply, I'm sure that we can actually break the transmission of COVID-19 in this country. Thank you very much. Yeah.
Thank you very much, Country. You have given us a very good update on what the government has done and is planning to do to help contain the COVID pandemic. As we said, there's a bit of time for some questions. We hope Country will be willing to take some of your questions. Please open the floor for anyone who would like to stand up and ask a question, but kindly identify yourself and let us know who you are. Do we have the first question from the floor? Yeah, ladies and gentlemen, any questions from the floor, please? Yes, can you please let us know who you are?
Assalamualaikum, Tan Sri. Good afternoon. My name is Hazwan from Dr. On Call. Congratulations again on your latest conferment of your title and all the good work. My question is, we have been going through this phase about 6 to 8 months now. And in the earlier sessions from the pharmaceutical companies, you're talking about the race to find a vaccine and antivirals. My first question is, what's your comfort level in terms of development of the vaccine? Second, there is a chance that we won't find a viable vaccine for a long time, right? How do you think we all should be prepared for that long period, or how things will change?
All right, thank you very much. We learned from the past, for example, SARS and MERS-CoV. Until today, we do not have vaccine for SARS and MERS-CoV, but we managed to eradicate SARS and MERS-CoV. So we have high hope. Hopefully, there's a mutation coming in, and then virus continue to mutate. So if this virus mutated to be a weak virus, and then probably it will just disappear. So that is a hope. But certainly, vaccine is also another hope. But again, before we commit into the vaccine, we need to look into more information. We have a dengue vaccine, but we are not using it because there is some phase 3 clinical data. We need the phase 3 clinical data for us to look into the response using that vaccine. For example, this SARS-CoV, for example, SARS-CoV-2, we noted the 3 things that's, the pathophysiology. Number 1, it causes pneumonia, etc. So that's number 1. Second, the virus also attacked the endothelial of the vasculature, and then cause stasis, and you get the clots. So the clots formation in the heart, you get a heart attack, and then we have seen our patient doing a post-mortem, the whole iliac arteries and all that been clotted. So if clots happens in the kidney, then your kidney failure, mesenteric artery, then ischemic bowel colitis, and etc. And the third is the antibody response. So interestingly, when we look into it, and today I think Hong Kong also published the same paper, and we were informed by our Chinese counterpart that we are exposed to, the patient exposed to the live virus, and then 3 months later they do the antibody. In China, only 17% IgG is still present. And UK also reported the same thing. We did a study, a small study, among our Sungai Lui Tafiz school. They are all infected with virus. 3 months later, we do the serology antibody, only 20% antibody, which means they can get a second infection. Today, I think our data in Hong Kong shows you can get a second infection. Why? Because your antibody is low. Normally, you get the infection, this is live virus, then you have the antibody to prevent you a second infection. But now, if your antibody IgG is low, then you can get a second infection. Then we ask ourselves, what about vaccine? Vaccine is live attenuated, weakened virus giving to our body. Do you have that kind of response? After 3 months, will there be enough antibody? We don't have data. So we need to look into data efficiency in terms of side effect, and all. So, but today, Russia has has registered the vaccine, and China has registered, but we have not seen the phase 3 clinical data. For us, before we purchase any vaccine, we need to look into the data first. Once we know the data is, and then we need to scrutinize the data. If it's safe, then probably we go ahead. If it's not, then it's difficult for us to invest in a vaccine that have not been proven. So this is an ongoing process, so we are looking at it. We certainly have hope, but we hope that they will find a vaccine in time. But so far, I think they are just embarking on the phase 3 clinical trials. The compound, about 22 compounds have been isolated, but the clinical trials, if I'm not mistaken, only 6 compounds gone into phase 3 clinical trials. But we hope for more data before we can conclude.
Thank you, Tan Sri. Another question, please. Okay, MMA President.
Thank you, Tan Sri, for recognizing. Tan Sri, first of all, everybody has called you a hero of the COVID infection. So we are also very proud as your colleague, as our medical colleague, that you are doing an excellent job. And I'm very happy that I'm able to, we have direct connection with you. So not necessarily I need to speak here because I think there are other people, but I think there are 2 issues that we need to talk about here. One is, while everybody is acknowledging, you yourself acknowledged when Tan Sri Ship was awarded, you said it is for all medical professionals and everybody who work. But the GPs, I don't want to raise this issue here. GPs are the frontliners for the last 60 years. And unfortunately, many of them have asked me here when I was talking to them, why the GPs did not play a major role. So that is some question that I'm not able to answer, though I'm the president for MMA. Why were the GPs not given, like in Singapore, the GPs played a major role in the thing. Secondly, I know you are a very staunch supporter of WHO, which I think is the right move. But are there not any other ways, apart from what WHO is doing, are there any other organization that you are able to bring forth? Because sometimes we have to support WHO. I think WHO is the best organization for health. So I'm wondering, are we strictly following, or you are only strictly following WHO guideline? The third issue is, I think most people have been talking about, and I think the Prime Minister, our Prime Minister answered it very well. Nobody is above the law. Everybody, any VIP or anybody who flouts the law as far as COVID must be given the necessary punishment. I think this is an example for common people. When people are made to pay 1,000 ringgit and all that, many of them suffer. I'm not saying that enforcement cannot be enforced. I think it must be regulated and it must be fair to the kind of people who are being charged. I know the reason is because I've been watching and I've been going around and I noticed that the second cluster, you're very worried. I can see every time you speak, you're talking about the second cluster or second infection. Even this morning I was walking in, most of us wanted to touch our hand. I had two young girls wanted to go and shake hands. I said, don't stop. I told her, not because I'm concerned, because the two young girls shaking hands may be good for them, but we are all senior people. My immune system is cracked. So if you shake and you try something, that's the main reason I think Tan Sri is most worried about is the seniors may not have the strength of the immune system that most of the young people have. So you are supposed to protect your parents and your families, not yourself. Thank you, Tan Sri.
Thank you very much. First and foremost, I'm only the symbol. I'm not the single person doing the job. There's a big team behind me, whether the public health, those frontliners, and also those working behind the scene. For PC, for example, for 15 minutes or 20 minutes PC, we have 150 people getting the data, analyzing the data, and etc. So it's a teamwork, and not only Ministry of Health, but inter-ministry as well. So the credit should not go to me. The credit should go to the whole team. This is what I'm trying to say. I'm only the symbol. So it's not me, it is actually the whole team. So one person cannot make a difference. But obviously, if you want to credit the Prime Minister, because he listens to us and makes the decision. We advise him, and then he makes the decision. So do you credit a person advisor, or you credit a person making that decision? So I think making that, you see, if the Prime Minister says, no, I'm not going to listen to you, just like President Trump, what's going to happen? So that will be disaster. You have the best CDC. All our public health will go to CDC and to have training in CDC. Plus, they have experts, but you are not listening to the experts. So I think the credit should go to the Prime Minister. That's honesty. Second is that when you look into it, our issue is public health is very important. Now the clinics, I know the clinic and the hospital, we have 4 components, 4 sectors. The lab is extremely important during the RT-PCR, for example. That's the recommendation. Second is the public health in the field. So we are trying to avoid patients to reach the hospital. That's why you are seeing now our hospital, we have prepared 8,000 beds, now only 184 patients in our hospital. So we are trying to use public health to prevent them from coming to the clinic and hospital. Then third, obviously, the public comes to in, even private hospitals not taking in COVID patients. They're all sent to the public hospital now. But we work closely because they are with the private hospital as well. So in the clinic, it's not that we try to isolate them, but the more important is how can you contribute in that sense. And now is the issue of testing. Testing will be the lab or the clinic. So if we are using RT-PCR as a gold standard, initially we have to resort to RTK antigen because we were short of the testing because we can only do 1,000 testing a day. Now to increase, then we are using, but RTK antigen, the sensitivity rate is 84.4% to 90%, but specificity is 100% as compared to RT-PCR. So that's one. But more importantly is that, the collaboration between the two. So if the GP, for example, during the crisis wants to come in, close their clinic, and then during the lockdown, and come and work with us. We have actually enrolled more than 2,000 staff, retired nurses and GPs coming to public sector, working with us. Some even specialists from the private hospital, anesthetists and all that. They took leave and then crossed over to join us as a team. So you can see the collaboration within the public and private sector coming together. So I think this is some of the success story that we have in the past. Then do I listen to WHO? Obviously, we are the member state of WHO, but not necessarily, because WHO will crunch the data and the analysis and then comes up into, and then put in the guidelines for us. But sometimes we are doing beyond WHO. So for example, recommendation of WHO is that you only screen a person when they're symptomatic. But asymptomatic also we screen. So it's not only positive cases that we screen or those exposed, but non-exposed also we screen. For example, we are doing the lockdown in one area. Whether you're exposed or not exposed, we screen everybody. So that is something that we do beyond what the call of WHO. But WHO is only one organization that, at least we can have a common discussion and issues and challenges we can discuss in that level. But we also work with DNDI. I'm the board member of the DNDI, Drug and Elected Disease Initiative. So we look into a new compound that actually can be developed. So we are in one of the trials as well. So we are looking into that. And also we are member of the SEPI. SEPI is a coalition of epidemiology, preparedness and innovation. This is where vaccine comes in. So we are involved in that, and then see how best we can work together with them. So it's not one organization. We are working with multiple organizations. So then we have G2G with China, with other countries as well. So collaboration, very important. Learning from the experience. We must not be in denial. We must learn from a country who have experience 2 months ahead of us. Now, for example, today we have seen data showing that in France, in Italy, in Spain, Hong Kong, Korea, they are seeing second wave now. Cases are surging up. Are we going to be relaxed here and be complacent? We need to prepare ourselves now. This is why today, this morning, I told the cabinet, I've told the meeting, inter-ministers meeting, is that we need to strengthen our border. So once the border has been controlled by the immigration, and then and also the illegal entrance by the army, and then we need to focus on control local cases, local transmission. And this is what we are doing, looking into the cluster, and then looking into the gaps. For example, one gap is shipping industry. They sign on and sign off using our ports. And then recently we have Jupiter cluster, we have Clevier cluster, we have all the clusters coming from the ship. Why? Because when sign on, that means someone from, for example, from Philippines or from Indonesia, they fly in, no quarantine, straight away they board the ship. So they can be source of infection. Sign off, for example, they have been to multiple ports and then they sign off. And in Labuan, for example, sign off, they're supposed to fly off, they went to shopping, for example, and then in the shopping mall and etc. 17 of them, the sailors. So we have no choice but then to take action. So now we need to put the protocol, the SOP in place for them. And they have to be quarantined as well. So I think this is the strategy, to foresee what's going to happen. It's too late. Once it's happened, it's already too late. Now the prevention part. So we are focusing on prevention rather than cure. So now you can see that because we are focusing on prevention rather than cure, hospital beds are empty. In ICU, we have 1,364 ventilators, but we are using only 5 ventilators only. So why? We are preparing. So preparedness is already in place. But if possible, we do not want our patient to be admitted to hospital. Prevent them from coming to the hospital. And then public health action comes first. That's why clinic and hospital, you are not seeing that many patients. But because of the efficient public health response and intervention before they become spread, then we have to contain in the field. That's what we are doing at the moment.
Thank you, Tan Sri. The lady there, please.
Thank you very much, Tan Sri. My name is Yuk Ling. I'm from the World Network. The other symbol you are very strongly for is actually public health. I think we've heard that very strongly from Dr. Zol earlier and yourself, because we can see obviously from countries like the UK, which we thought had a strong NHS, but which has been so fragmented that there is no real public health response. I think it's something that's a very clear message we have as Malaysians. So I really do think that it is very important for us to strengthen the public call for more investment in public health. So we're all behind you on that. I just wanted to ask you 2 questions. One is that the treatment options, all the different, from hydroxychloroquine to even remdesivir, which is actually kind of hyped up. So what is our preparedness? Because we don't see anything that is really very promising. So part of that, if we expect a second wave, what are your plans? And the other thing is about keeping the borders closed is obviously a very important part of the strategy. But we do have hundreds of families who have Malaysians married to non-Malaysians, and they have been separated because of different immigration requirements. But many of them, there is a health component because many of them came back for having babies or their illnesses or taking care of their parents. So there's a lot of psychological and emotional stress. So wondering whether we could also find a solution while we have to keep the borders closed to deal with this aspect of Malaysian life. Thank you very much.
Okay, thank you very much. We inherited the British system, and we are evolving our system, the British system, and they have fragmented, whereby the public health and then all the agencies have been fragmented. I think we are lucky because we have a fast response. Why? Because the DG is in charge, and then basically the command is the Director General of Health. So from the lab to the hospital. So the coordination is important. We make a decision, every morning we have meeting, we make a decision, tomorrow we can implement it. In the UK, for example, they make a decision, then they have to go to another organization, another head, another system. That delays it. Fragmentation, they are good in details, attention to details, but not in general. So I think our advantage is that because the DGs is in charge from the lab to the pharmacy and everything, so every morning at 8 to 9, we have a meeting. Coordination meeting, inter-ministry. So, all the issues we discuss. 9 to 11 o'clock, we have an inter-ministry meeting every day without fail. Then at 11:30, we brief the Prime Minister to 2 o'clock. 2 o'clock, I have to rush back to crunch the data. 5 o'clock is my PC. After the PC, I have to download all the information into the social media, etc. And then at night, if we are doing a TEMCO or even an enhanced MCO, then we have to look into the areas, planning, etc. until 11 or 12 o'clock. This has been the routine that we have been doing for the last 8 months. That's why I lost 8 kilo, My waist used to be 36, now it's 34, for example. So I can put on my pants 10 years ago or 15 years ago. But that's beside the point. The point is that, we are working as a team. This is why I think I appreciated this experience. I think all of us appreciated this experience because this is in our lifetime. We may not even have this experience. Taking charge in terms of whole government, listening to Ministry of Health. That's the one. Then when you talk about research, yes, we look into all the treatments that we have. Start with hydrochloroquine, etc. But you must understand that when we started, we used hydrochloroquine, we used dexamethasone, we also use lopinavir, ketonavir for the HIV. But these are all off-label use. But we tried it, and we looked into the response. And we use our own data, not following the data from overseas as well, but we look into our data. But when you look into hydrochloroquine and dexamethasone for ill patient, because it's not hydrochloroquine alone, but we also use dexamethasone. Maybe it's the dexamethasone that works. That's why now the report is dexamethasone. So we have HCT, there's no difference clinical significance in terms of using HCT. So we have dropped that. We also started using, first wave, we use ketonavir, lopinavir and ketonavir. But again, this the treatment used for HIV. And then now we have evidence to show that it's not working. So we have dropped that as well. So we are looking into all the new drugs now, remdesivir, for example. So we look into the clinical trials. We base on facts and data, evidence. If the evidence is not strong, then why should we invest in that kind of medicine? So unless it shows a good evidence. But what we do know that when the patient comes in, you must start the DEXA as soon as possible. And then also low molecular weight heparin because of the clots formation. So you have to prevent the clots, so you start the heparin, low molecular weight heparin. And then the treatment, symptomatic treatment, etc. So I think this is how logistic. Today we are talking about remdesivir. Do we want to invest in remdesivir? If the evidence is not strong, why should we invest in the remdesivir? I even don't want to fight it under the compulsory license or voluntary license because until the data shows that this is a treatment. Today we have no strong data to support the treatment yet, so it's still under clinical trial. We are involved in clinical trial, solidarity clinical trial with WHO and the DNDi, and we are coming together to look into it. So this is why this is a new virus, only 8 months old. So there are a lot of things that we need to learn. Every day brings new lessons and challenges. So we need to see where we are and how can we move forward with this virus.
Thank you, Tan Sri. Sorry, you really couldn't recognize it with your mask on. You and Martin Koh and Third World Network has been contributing a lot to many, many issues. Can I invite the next question? Anyone with the next question, please? Yes, can you please let us know?
Assalamualaikum.
Salam.
Sri.
Yeah.
Congratulations, Rahim from MSPH.
Alhamdulillah.
Tan Sri, this morning there was lots of discussion with regard to telemedicine and digital healthcare and so forth. I was wondering if Ministry of Health is looking to this. As you can see, the collateral effect of COVID-19 is a surge in use of telemedicine services. I was wondering whether Ministry of Health is looking at guidelines to ensure that the standards of care remains.
So before I answer that, I think there's a question there. Nobody is above the law. That's why I'm saying that nobody is above the law. Whatever happened, because it was out of our knowledge. I and the top management only realized of this issue last week. So what we did, the first thing is that we have an internal investigation. Yesterday only I got the report for the internal investigation, and there's actually issues and challenges at the ground level. So if the ground level is not informing the top management, how can we defend them? So that's one issue there. Now it's a police case. We'll let the police to take the action in turn, investigate fully and etc. But there are issues with regards to the frontliners. The frontliners, whether you're in the lab, whether you're in the clinic, whether you're in the field or in the hospital, there is a set of rules and regulation. We call it guidelines in terms of clinical practice guideline. You have to comply to that guidelines. And then in the management, there are things to do and not to do. But if the frontliners is not following that, for whatever reason, then the onus is on the frontliners. I remember Tun Mahathir once, when he took office, he told us, if you have been pressured, you are the one that signed, and the person signing whatever it is, you are responsible, right? If it's wrong, you have to make sure that you have inform us and then do the action and etc. But if not, this is why the frontliners must comply. For example, if you are in the lab, you are supposed to put on a PPE. If you don't put on a PPE, you get the infection of us, right? You have to protect yourself. So we also have to protect our frontliners. For example, going to the field, you have to follow the rules and regulation in the clinical practice guideline as well. If you do not follow that, you breach that, then you are breaching the Act 342, then the virus actually can come into community. So I think these are all issues of administrative issues we're looking in, but I'm not quoting that case. That case will be under the police. Police will investigate. But more importantly, when we advise the public to comply to SOP, we must also advise to our frontliners to comply to the clinical practice guideline in terms of the lab, CPG, and etc. So very important for our frontliners. But if you do not comply, you are exposed yourself to the virus. You are exposed yourself to all the challenges that we have today.
Thank you, Tan Sri. One more question from the floor.
And then answering your teleconferencing, telemedicine. Yeah, today I think in terms of preparedness, is lacking behind is telemedicine. Why? Because during the crisis, then only we come up with MySejahtera, we come up with all the software, not before. So I hope that in time to come, we prepared all these teleconferencing, telemedicines, IT, before we have the pandemic, before we have the infection. Now, not during the infection, now we come up with all the software and etc. That is reactive. It should be proactive. So I think there is still a lot of room for us to improve in terms of using telemedicine, ICT in our. You look into today, for example, we are adopting in terms of the graph. We can predict where we are. I told the Prime Minister on the 16th of June, we will have the cases will be a single digit. He doesn't believe me 3 months ago. He said, don't even publish that. Because, whether we trust the data in terms of the prediction using our SIR model, for example. So now I think the trust is there. So I hope that the telemedicine in the innovation, creativity should be done before we have the crisis or before we have the pandemic infection. So that is where it's a proactive. I would like to see a proactive rather than a reactive management.
Thank you. Over to you.
Thank you very much. I'm Soraya from Alpha Catalyst. With regards to telemedicine, your question, do you see a change in appetite for our policymakers, therefore, in terms of shifting policies, especially in terms of telemedicine, allowing online healthcare to come on board?
Yeah, telemedicine has given us a jump start. Now, because of the crisis today, I think I hardly attend a physical meeting now. It's all webinars and etc. So this is, I think, the first time I'm attending a meeting like this. A second time, I think, with the meeting before. But more importantly, we are using this opportunity for us to embrace telemedicine and to look into the coordination of data between the public and private, because every day I have to give the data, and the data must be collected from the public, private, university, etc. Unless we have a system that already been prepared early in terms of the lab reports, in terms of the cases, in terms of hospital, and beds, for example. I want to know how many ICU beds available. Can I just, using the computer system to look into the available of beds, available of medicine, all that should be in place. Then we are talking about proactive rather than reactive. Then only searching for data and trying to integrate. We are trying to integrate now, but we should be integrating the private sector and public sector long before. So these are the challenges that we have, but I think we can improve it over a period of time.
Thank you, Tan Sri. Any other questions from the floor?
Oh, you can ask me anything, actually.
Yes.
I was just wondering, you have touched on a very important
Your name,
issue.
please.
Sorry?
Your name, please.
Sangeeta from Pradana University. You have touched a very important subject matter just now, how the collaboration between intersectorial is working. And I was thinking that, is there any thoughts towards integrating public health into other ministerial, such as Ministry of Education or so forth, so we can address issues like teachers going on holiday during this COVID-19 period?
Yeah, but now I think this is in crisis you have opportunity. This is a time that we have opportunity to showcase public health. If our administrator do not trust public health, once upon a time we said public health not important, we focus on more cardiology, clinical. I think that is a wrong management. So now this is the opportunity to showcase public health, and then we should train more public health experts. And if we want to look into public health, the figures of public health in this country, the personnel is actually decreasing, not increasing. Why? Because once upon a time we do have many public health experts, then they retired, and we are not able to catch up with the figures. What more trying to expand the public health to other ministry? We don't even have enough staff in the Ministry of Health. So the investment in future must be in public health. More money and etc. in public health. I think that shows a recognition of public health. And for example, during the crisis, public health has been recognized. The King and Queen visited CPRC. The King and Queen have not visited my office, but CPRC. The Prime Minister visited CPRC. Deputy Prime Minister visited CPRC. That shows that the recognition be given to the CPRC for the first time. 10 years ago or even 5 years ago, nobody knows what is CPRC. Today, everybody knows that CPRC is actually the most important department that we have in terms of coordinating with CPRC from the HQ with the states and etc. So the network must be well established. So I think this is an opportunity for us to sell public health. And I'm a surgeon, but to me, if you ask me, if I were to start my career again, I would certainly do public health. But since I'm in public health, I'm also fighting in terms of global surgery. It's a public health issues in terms of surgery. Surgery is a very important component. So we are working closely with the Harvard group to look into global surgery. How can we provide access to surgery, basic surgery in the rural areas and etc. That is also a public health. So combining my surgical experience and sharing with the rest of the world, we are using surgery as a platform for public health.
Thank you, Tan Sri. Anyone else? Yes, Carol?
Hi, my name is Caroline. I'm from KSI. Here I'm speaking not from KSI view, but as a public citizen. Under the Prevention and Control of the Infectious Disease Act, the fine for quite a violation of the quarantine or anything is only 1,000 ringgit.
That's right.
Is there, has the ministry any plans to increase the fine?
Yeah. Okay, now we are looking at Section 25. Section 25 allows the GG compoundable offence, maximum 1,000 ringgit. And last 2 weeks, I think in the parliament, they wanted it to lower down to 250 ringgit. So we disagree with that because this is a compoundable offence. We are talking about compoundable offence. For example, putting on mask. So if you are compounded, then it's about 1,000 ringgit. So we hope that it can push to 10,000, but it's up to the parliamentarian to decide. The act enacted, drafted in 1988. Probably in 1988, 1,000 is reasonable. But now we look back in terms of, do we need to review that? So that's why we are talking about compoundable offence. Then we have the Section 24. Section 24 is not a compoundable offence. It is a violation of the order. So violation of order, for example, home surveillance order, must be printed just like MC, you have to printed and give to the patient. So once you have been given the home surveillance order, if you violate the home surveillance order, it comes out of the Section 24. So this is why the issue is the issuance the home surveillance order and put on the bracelet and etc. So this is the act. So we need to perhaps relook back again the quantum, whether we need to increase or not. So I leave it to the parliamentarian to decide.
But the thing is that the ministry can always make the recommendation.
Yes, we did. I think you look in the parliamentarian parliament the other day. We are putting a proposal about 10,000, but it takes time for us to push that bill to the parliament.
We just hope that the parliamentarians, take note of that, because at the end of the day, there is a perception that some away can get away with it. Got away with it.
Actually, nobody gets away with it. You see, the thing is that the issue is even the king and queen, they've gone through the 14 days quarantine. Even the prime minister, when she is exposed to a positive patient, we insist that quarantine 14 days and issue the home surveillance order to the prime minister. So now the issue is with this case, because I said, all of us, we are in the dark. We don't know about it. So if you do not know about it, you start on an investigation, internal investigation, and police will investigate. We already have empowered the police under Section 3. That is actually a public officer, for example, to look into, to help us in terms of enforcement of the Act 342.
Thank you.
Any other question? Yes, please. Let us know your name as well. Thank you.
Assalamualaikum, Tan Sri. I'm Jalifa Fenner. I'm from the Selangor Tourism Association. I have a very simple question. The current PKP ends up on the 31st of August. So what happened next? Number two, the tourism industry is talking about opening up borders because business is bad, hoteliers are suffering. Lots of people are losing their jobs in the industry. So what is your advice on this matter? Thank you.
So we have to look into the global situation now. So it's going to be very challenging. The moment we open up our border, that's beginning of the end. And then we get a wildfire we can't control. So we will tighten the border. As far as tourism is concerned, we will continue to have this RMCO. Today, for example, during the period of RMCO, we revived the economy, we revived the social, education, and even the tourism sector. But if you look into tourism in this country, 60% of the income comes from the domestic tourism. So why not we focus on domestic tourism first? So, and we can control and make sure that they comply to the SOP. So if we can do that, we cannot perhaps just to sustain this year rather than making a huge profit. But if we can sustain this year and next year, probably that's a way forward. Because the moment we open the border and the infection comes in, it will be a worse economic situation for tourism, for social, for education, and everyone. So I think we need to have a, look into it in a bigger picture rather than just focus on the industry. But I'm sure that we can actually stimulate the local domestic tourism. Today, I was informed even in Malacca, in Langkawi, it's fully booked, the hotel. So that shows that we can revive the local domestic tourism and control the situation. Most important, you are able to control and comply to the SOP.
Thank you. Yes, please.
So PKP ends, but then as I said, the situation today, you look into not only Malaysia, other countries, the spike is going up. So if the spike is going up, we need to re-look again whether it's not possible for us to end. So end means that means if we end 31st of August, then we do not have the Act 342 to enforce and to make sure people comply. So if the situation, global situation is improving, then probably we can think about, there's no need for me to make a decision, but the Prime Minister will make a decision based on the facts globally and locally.
Thank you. Yes, gentlemen.
Alan Fernandez from the Asia Clinic Group. Good afternoon, Tan Sri.
Good afternoon.
I just want to, I know we're many months away from a viable vaccine, but assuming one is found and it's approved, is there a national immunization program planned? And if so, could you shed some light on what we can expect from it?
Yeah, we do have a national immunization program going on, but again, we need to look into evidence first before we commit. Like dengue, for example, they wanted to put into national immunization program. We were very hesitant because the data shows that the seronegative patient we are worried about. But then other countries, Philippines took off, as a pre-election campaign, and then they took off the immunization for dengue. And then we study the impact and their death and etc. So that's why we are quite hesitant to start. So that's why we need to look into the data first before we can commit. If the data is, evidence is strong and the side effect is less, and then probably we will invest in the vaccine.
Hello, good afternoon, Tan Sri. My name is YC from Alpro Pharmacy. So this morning we have discussed a lot regarding telemedicines. Even Tan Sri yourself has also mentioned that it should be a proactive approach rather than a reactive approach. So my question is, how much is the readiness of Ministry of Health in promoting and also developing telemedicines and e-pharmacy? And how much is the government's political will in doing this? Because coming from the background of healthcare, we know that the current sets of legal frameworks, there's no control on this. The Medical Acts, the Pharmacy Acts, and everything in Private Healthcare Facilities Acts and everything doesn't include this. So for us to do this part, it is actually a little bit difficult, especially when we want to come out with something new. We have to actually sit down with the policymakers and then, start from the beginning to actually explain how is the concept. So is there any organization or any plan in the ministry to actually push these things forward? Thank you.
Thank you very much. We have in Ministry of Health, we have telemedicine department before, but it's been done in very piecemeal. So I think the solution is that it must be a whole government and whole society approach coming in, look at telemedicine as a whole. And obviously, when we can plan, I think planning has been taken place for more than 10, 15 years, but the investment now we're talking about, invest in healthcare. Do you know that investment in the Ministry of Health, health sector is only 2.3% of the GDP, and total investment is less of 4%. Other countries are talking about 10%, US about 18 to 19%, most countries about 10%. Our investment is only 4%. So if we can push up to 6%, then probably we have more budget for us to invest in healthcare. We are maximizing every ringgit that we have for the healthcare system. And for 2.3% of the healthcare system, we are doing fairly well. You compare to Korea, you compare to other countries, our investment in the public sector is very, very low, it's 2.3%. So we hope that this is an eye-opener for us to invest further in health. Health is a wealth. How many of us believe health is wealth now? Probably this is the eye-opener, hopefully more investment in health. Then we can plan for the hospital. Only 25% of hospitals have IT system, EMR. 75% is still lacking behind. So, and we need to look into the whole spectrum, not only in Klang Valley or in big towns, but also in the rural areas. How can we use, a whole government approach to come to a solution to prepare ourselves for the next pandemic?
One final question, please. Yes.
Hi, Tan Sri. Once again, congratulations on the new title. My name is Dr. Raju. Previously, I was with Bernama, and I'm also a medical doctor myself. Just wanted to check with you, Tan Sri, what are your thoughts? Soon we will face the end of a moratorium. We expect a lot of people to face unemployment. Companies are cutting down on costs for healthcare benefits. The private healthcare system is seeing quite a significant drop in number of patients showing up at the hospital for various reasons. And I expect or anticipate that the public system is going to be overwhelmed shortly. So apart from dealing with the crisis in the COVID front, what are your thoughts or what's our preparedness level, to take on this influx, this sudden surge that might come soon?
So when you look into the healthcare system now, the private and the public, we have been planning this and talking about the healthcare system in the country for the last 35 years. We are trying to integrate the public system. GPs, for example, how can we use the GP in the private sector, in the public sector? Now, to integrate, then we have to address the issue of cost. Who is going to pay? So that's why I think we are talking about in terms of the insurance scheme, public insurance or social insurance, for example, thereby the public, for example, the rich and poor have an option. So if the hospital is good in public sector, you can go to public sector, then we cater for the public sector and even the private. Now the private is coming to public hospital as well. But the poor have no option. They only go to public hospital. So unless they also can go to GP being paid, for example, they also can go to private hospital. That is what I think will be ideal. Now we are using the PKB40, so in terms of screening. So we hope that we can move towards treatment, and by the GPs, for example, they can treat and be paid by PKB40. And then eventually hospitalization also be paid. But this is only B40 we are talking about. But what about the M40 and the T20? So if we can integrate a system or social health insurance that we can crisscross within public sector and the private sector for the rich and the poor, that is ideal. But we have been discussing it. We need strong political will to do it. Everybody talks about it, but I have been there for the Ministry of Health more than 13 years. But it needs strong political commitment to come up with this. So we hope that we can use this platform in PKB40. We started with the screening. The next will be the treatment in the clinic, and then the next will be in the hospital. But we are only looking at B40, so not good enough. We need to look at STIPA, for example, foreigners as well. We need to look at the M40, then probably the T20 as well. So if we have been, given another 2% of the GDP, certainly the money, we can use it to invest in the healthcare transformation in this country.
I'd like to bring this to a close. I want to thank Yang Berbahagia Tan Sri Dr. Noor Hisham for this open dialogue and for your very frank and candid replies to the many questions that have been put to you. We wish you and the Ministry of Health continued success in the fight against COVID and in all of the future plans of the Ministry of Health. Thank you so very much.
Thank you.
Thank you, Tan Sri, for the special dialogue and interacting with our delegates, and congratulations once again for receiving the National Icon Lifetime Achievement Award. As a token of appreciation for his kind presence with us today at the Malaysian Healthcare Conference 2020, I would like to invite Yang Berbahagia Tan Sri Michael Yeo, President of KSI, to present a token of appreciation to Yang Berbahagia Tan Sri Dr. Noor Hisham. Thank you, Tan Sri. I would like now to invite Tan Sri Majid Khan, Tan Sri Michael Yeo to accompany Tan Sri Noor Hisham to the VIP holding room for some refreshments.